Hello and welcome to Chapter 425 on the natural history of cerebral aneurysms. I'm Richard Wynn, and I'm going to present this supplement to our chapter. I want to acknowledge my co-authors, Gavin Britz, who's chair of neurosurgery at Methodist Hospital in Texas and professor of neurosurgery at Cornell. And also want to acknowledge the contribution of Carl Schaller, who's chair of neurosurgery and professor of neurosurgery at the University of Geneva. I also would like to remember these two individuals who contributed so meaningfully to the natural history of cerebral aneurysms and with whom I worked for many years. In the middle is Alan Richardson, who was at that time the head of neurosurgery at Atkinson Morley's Hospital in Wimbledon, England, where many studies were done on the natural history as well as different forms of treatment. And Alan, at the behest of John Jane, also pictured here, who was the professor of neurosurgery at the University of Virginia, where I trained and subsequently was on the faculty. At the behest of Dr. Jane, Mr. Richardson took me on as a research advisor, and I worked with Mr. Richardson, supported by a number of grants that we were fortunate to obtain from American Heart Association, and a variety of foundations in the UK to support our research documenting the natural history of cerebral aneurysm. I might point out that Dr. Jane preceded me in this effort by a decade and spent a year as a research assistant to Sir William McKissick in the early 60s. So, natural history of cerebral aneurysms. And here's a quote from a paper we wrote in 1977, which stated, although cerebral aneurysms were first recognized in 1761 by Morgagni of Padua, the correct management of this potentially lethal lesion is still unclear and depends upon an accurate knowledge of the natural history. And this was true in 1977, and many years later, to a certain degree, it's still true today. Now, what about the natural history? Why is it of interest in the modern era? Well, there's a little history that I would like to review with you, and that is that in the third quarter of the 20th century, the natural history of ruptured cerebral aneurysms was a topic for intensive focus related to the high mortality and morbidity associated with the treatment of aneurysms and the desire by clinicians and epidemiologists to identify which patients were at greatest risk of suffering a rehemorrhage. After all, in those days, the risks involved in surgery were significantly greater, and it was unclear whether surgery was of benefit to patients who had suffered a aneurysm hemorrhage. With the advances, and by that I would mean post-1975, in the diagnosis, advances in anesthesia and in surgery, the risks of treatment decreased, and almost all patients soon were considered to be candidates for direct repair of their ruptured aneurysm. Consequently, interest in defining the natural history waned. However, with the advent of CT scanning, which I might point out was developed by Hounsfield and Ambrose at Atkinson Morley's Hospital, with the advance of CT scanning and MRI scanning post-1980s, and the increased ability to discover intact aneurysms, clinicians and epidemiologists again became interested in more accurately defining the natural history, with now an increased focus on unruptured intracranial aneurysms, which are known as UIA. Now, most recently, the introduction of cerebral interventional techniques not only added neuroradiologists to the interest group, but also made the need for defining the natural history more compelling. This is especially true for defining the long-term natural history as compared to the long-term outcome of interventionally treated aneurysms. So my discussion today will be divided into two parts: unruptured natural history, and then I will turn to focus on the ruptured natural history, and again divide that into two parts: the acute natural history as measured from 0 to 6 months, and the long term, that is greater than 6 months. And each of these aspects is symbolized by this sword hanging by a thin thread. And that's illustrated in this painting by Westphal of Damocles, shown here, who was a supplement to the king, and felt that the king's job was really all fun and no tears. Perhaps you could use the term chairman of a department to stand in lieu of the king. But in any event, the king said to Damocles, "If you think it's so easy, here, sit here and be cared for by all my servants." And it was that point Damocles looked up and saw this sword hanging by a thin thread, which he did not understand, but then soon gained the insight that that thread could break instantaneously, and boom, that would be the end of Damocles. And that, in a sense, capsulizes the natural history of cerebral aneurysms. So, getting on to this supplement to chapter 425, the natural history of any disease is defined as the outcome of the disease in the absence of any intervention. So the natural history of unruptured intracranial aneurysms is defined by the incidence of aneurysmal subarachnoid hemorrhage, or the rupture rate. And the rupture of intracranial aneurysms if ruptured aneurysms is defined by the most accurate way to define it is to follow unselected, conservatively treated patients, that is, relegated to bed rest. And in today's modern times and treatments, this type of population is no longer utilized. It's undoubtedly not the optimal, from an ethical point of view, group to study. I want to go through a series of definitions before we get into the meat of discussing the natural history. Again, we're going to focus on initially the unruptured aneurysms. So prevalence. Prevalence is defined as the individuals with disease over the population at large. So this is not a defined population, it's the general population. And the prevalence of unruptured aneurysms in the general population has been found to be anywhere from 0.2% to as high as 9%. And this is the table 425.1 from chapter 425, and it reviews more than 20 plus series, and is divided into how the patients were diagnosed or the aneurysms, unruptured aneurysms, were found. So it's broken into autopsy, angiography, CT scanning, MRI, then meta-analysis, and then there's a separate group on de novo aneurysms in an attempt to better define the natural history of the development of cerebral aneurysms. So what could account for this rather large spread from 0.2 to 9% in an attempt to define the prevalence of unruptured aneurysms? Well, it's pretty obvious that the methods of discovery may explain the wide disparity. So, for example, if you look at autopsies, there's a variety of numbers and percentages here, and to some degree, it depends on what the neuropathologist or even the pathologist defines as an aneurysm, number one. Number two, how carefully perhaps the brain cutting was done. Let's look at radiology, and we'll use catheter angiography as an example. Here's a study that we did in the early 70s and published subsequently, consisting of more than 4,000 patients. We found only a prevalence of 0.65 instead of a study out of Japan found that 2.7%. What could account for it? Well, the age of the population in the Japanese study was much older than the population done in the United States at the University of Virginia. What about population-based studies? These tend to be less selected. And here we can see two of the larger studies, both from Scandinavia and actually by the same group, separated by a number of years, and finding of approximately 3% incidence of unruptured aneurysms in the population. So what are the factors that have been associated with the increase in prevalence? And I want to emphasize the word associated because, after all, these are only correlations between an observation and the observation of an unruptured aneurysm. So gender, females appear to have a higher risk of developing an aneurysm. Age, patients over 30, is the conventional breakpoint for looking at where the incidence of aneurysms is increased. Location, there are locations within the cerebral circulation where aneurysms are usually found. There's some suggestion that there's variation in nationality, the presence of hypertension, wall stress and hemodynamic factors, genetics, and here I would refer you to chapter 425, beautifully written, a very thorough chapter on the genetics of intracranial aneurysms, and then lastly, lifestyle such as smoking, alcohol use. And these factors you will hear repeated over and over again when we get into discussion of rupture rates and even a natural history of ruptured aneurysms. So I've defined prevalence, which I indicated was individuals with disease over population at large. Let's turn to another term, that's incidence. Now here the population at risk, or the population at risk is the patients who develop an aneurysmal subarachnoid hemorrhage, whereas the population at risk is not restricted to the population at large, but is those patients who have an unruptured intracranial artery aneurysm. And it's usually defined as per 100,000. And there's a third term, so we had prevalence, incidence, now rupture rate. And rupture rate is the risk of an unruptured aneurysm bleeding over a specific time period, usually by convention over a 12-month period. And both of these are important bits of information, but really it's the rupture rate that is most applicable in the clinical setting, because after all, neurologists, neurosurgeons don't see 100,000 patients at a time, but really see one patient at a time. And that one patient and their family want to know what the risk is that this unruptured aneurysm may hemorrhage and strike the patient down. So, going back to incidence, as with prevalence, there's a wide range in the literature for the incidence of subarachnoid hemorrhage. And as with prevalence, these differences may be explained by several factors. For example, methodology. And here's a study by Wrinkle. Retrospectively studied versus prospective populations, retrospectively less than 1%. In contrast, prospectively 4.3%. What about the diagnostic accuracy? CT versus MRI versus MRA versus catheter DSA. All of these have a increasing threshold to detection and success of demonstrating an aneurysm. So depending on what modality is used and with or without contrast agent, that will affect and influence the incidence that's found. The biology of the patient, of the population at risk. So gender, again, comes into play. Aneurysmal subarachnoid hemorrhage is more common in female, although some studies suggest that females equal males after menopause. Age, I've already discussed that in regard to prevalence, but here it comes up again. Most earlier studies indicate that aneurysmal subarachnoid hemorrhage increases with age, whereas some more recent studies by Conley et al. Suggest a complex relationship with gender. That is, that males predominate in a younger age group, females in an older age group, and over the age of 85, males again predominate. So a U-shaped type of curve. Nationality, again, here's the incidence of aneurysmal subarachnoid hemorrhage. And you can see, depending on the location, and sometimes even within the same country, here we have two prefects in Japan, another one with different rates. And this is demonstrated in more detail in Table 425.3 and discussed extensively, so I'll refer you to the written chapter here. Behavioral and environmental factors such as tobacco, alcohol use have been suggested as being correlated with the incidence of aneurysmal subarachnoid hemorrhage. And there's increasing evidence, first suggested by Conley, that the incidence may be decreasing with time. And that may be related, for example, as you will see subsequently, by the decreasing smoking rates. So I discussed prevalence, wide range. I discussed incidence, likewise, fairly wide range. Let's turn now to rupture rate. And as I said, for the clinician, I think this is the more important number. And the risk of rupture, just as in incidence and prevalence, varies considerably. So from as low as 0.05% to greater than 5%. But most studies suggest a 1 to 2% risk per year, and that's demonstrated in 425.4, which is shown on this slide. It's a lot of small print here, so I'm not going to go into it. Just refer you to the chapter, although we'll discuss various aspects of it. But there's some interesting historical, this is arranged chronologically, interesting and thoughtful studies done well before the CT era. So let's look at studies when CT scanning and angiography technology were at the point where the miss rate was not a significant factor. So here's a study from the Mayo Clinic by Weibers in the New England Journal of Medicine. He identified retrospectively 65 patients with unruptured aneurysms and followed them for more than 8 years, found a 1.7% per year risk of rupture, and there was an increased risk in size and multiplicity. He followed this up with another publication 10 years later, which added to the 65 patients and then had 130 patients and found a similar risk of approximately 1.2% per year, or 1 to 2% per year. We did a study in 1983 out of Atkinson-Morley's Hospital where we followed 130 multi-aneurysm patients in which at surgery only the offending or ruptured aneurysm was clipped, and these patients we then followed for more than 10 years. And we found, again, a 1 to 2% per year risk, and that risk was related to size and hypertension. And most other studies revealed a similar risk of about 1 to 2%. But then in 1998, this seminal publication in the New England Journal of Medicine found that the cumulative rate of rupture of aneurysms that were less than 10 millimeters in diameter at diagnosis was less than 0.05% per year. That's mathematically 0.0005. So this was not as had been found in earlier studies. The study in the New England Journal was a retrospective study in one phase and a somewhat prospective study in a second phase. But note that 50% of the patients in this study, the initial phase, had aneurysms less than 10%, less than 10 millimeters. So these were not giant aneurysms. So what's the explanation for the disparity in observation in the yearly rupture rate as reported in the ISUIA study of 0.05%? That's a study that was published in '98 in the New England Journal, and the previous studies of 1 to 2%. Perhaps it was related to bias in the patient selection and the retrospective analysis, although many of the earlier studies were retrospective. So to test the hypothesis that the incidence of rupture for aneurysms less than 10 millimeters was 0.05%, or mathematically 0.0005, it's relatively easy to test. So at that time, 1998 through perhaps 2005, 30,000 patients per year had an aneurysmal subarachnoid hemorrhage in North America, Canada, and the United States. 50%, based on the ISUIA study, of these aneurysmal subarachnoid hemorrhage were secondary to aneurysms less than 10 millimeters, i.e., 15,000 subarachnoid hemorrhages per year, half of the 30,000. So if the rupture rate is defined by this formula, that is aneurysmal subarachnoid hemorrhages in 1 year over the population of risk, we can then do some calculations, admittedly not very complex. The yearly rupture rate was found to 0.0005, which had to be equal to the observed aneurysmal subarachnoid hemorrhages over the population at risk, i.e. the unruptured aneurysm population. So let's go through this. Then it follows that 0.005, we know that 15,000 patients, that is half of the 30,000, had small aneurysms, less than 10 millimeters, and ruptured. So we can solve for X to define the population at risk. In other words, the population walking around with unruptured aneurysms. And when we do that, this X becomes 30 million people in North America have an intact aneurysm less than 10 millimeters in size. And if 30 million people in North America have an unruptured aneurysm less than 10 millimeters, and the population of North America at that time was approximately 300 million, then the prevalence of unruptured aneurysms less than 10 millimeters is 10%. But there's some caveats. The population at risk is not the total population, but those greater than 30 years of age, or 58% of the population. In other words, it's not 300 million, but it's the adult population. That would be 180 million. Therefore, the age-corrected prevalence is 30 million divided by 180 equals 16.6% of the age-corrected population. But remember, that 16% is only for aneurysms less than 10 millimeters in diameter. So we now can ask the question, does 17% of the population in North America have an unruptured aneurysm less than 10 millimeters in size? And because the 10 millimeter sized aneurysm in the USIA study was 50%, we have to double that number, and then for all aneurysm, irrespective of the size, does 33% of the population in North America have an unruptured aneurysm? In other words, if you do 100 MRIs at a neurosurgery, neurology center in a day or a week, you should discover 33 with 100% pickup rate patients with unruptured aneurysms, but most likely less than that if the data from the USIA study is correct. Well, let's look at the pickup rate of unruptured aneurysms on angiography. And here's a study we did at the University of Virginia before the introduction of CT scanning. So this is an unselected population, although not totally unselected because they had to have a reason to have angiography. And what we found, and I won't go into detail, is that by reviewing 4,568 angiograms, it yielded 3,684 patients, 24 of whom had an unsuspected unruptured aneurysm, or 0.65% of the studied population, and not 33% of the population. Something doesn't add up here. Here are the facts. It's unclear about whether the bias was introduced into the study from the New England Journal of Medicine and skewed the numbers in a way that didn't represent the true natural history. Well, with that polemic, let's go on to some facts. So we're going to look at the risk of rupture of intact aneurysms, and we're going to take them in groups. The first is the aneurysm factors, and then the patient factors. In the chapter, it's reversed, but let's go first with size. There's good evidence that the risk is related directly to size, with a suggested threshold of 7 to 10 millimeters. And this was subsequently shown in 2012 in a study out of Japan published in the New England Journal of Medicine. You can see here's the giant aneurysms, the small, and you go down to 10 to 24 and then lower and lower in diameter, and the rate goes down. But small size does not preclude rupture, and that's become more evident more recently. For example, the study published in the Journal of Neurosurgery in 2019 followed 2,839 patients with aneurysms less than 5 millimeters, and found for 3 millimeter aneurysms a 0.3% per year risk of rupture, and 4 millimeter aneurysms a 0.54% risk. So even though at some point it was said that small aneurysms really are not at risk at all to rupture, it turns out that the facts do not comport with that statement. Small aneurysms do go on to rupture, but the risk is considerably smaller than larger aneurysms. What about volume rather than size? And here's a study by Juvella from 2017 and Corja, and they noted that the aneurysm volume seemed to predict future rupture, but the volume correlated with maximal diameter, and consequently, volume added little to the predictive value compared to maximum value. So volume is just a signpost for size. What about shape? Well, shape early on during the angiogram era, as demonstrated by Wood in 1964 in a publication in Journal of Neurosurgery, early angiographic studies were very supportive that the shape and frequently the occurrence of a daughter aneurysm was a harbinger of a future rupture. Recent analysis suggests an association with multilobarity and irregularity. What about wall stress, biophysical aspects? This has become a very hot area and intensively studied, whether it's the properties of the wall, the hemodynamics of blood flow, shear stress. Many publications are evaluating these factors, and it is at the present time somewhat similar to the three blind men examining an elephant, with frequent pronouncements that one factor appears to be more dominant than the other, whether it's the tail or the trunk, remains to be seen in future studies. Location. I think this is a somewhat old story preceding the publication in the ISUIA study in the New England Journal, which found that basilar bifurcation, posterior communicating artery, and posterior cerebral artery had a higher risk, and more recently, ACOM artery aneurysms had a higher risk than anterior cerebral artery aneurysms. And in contrast, again, based on the New England Journal article by the ISUIA, cavernous carotid and ophthalmic artery aneurysms appeared to have a lower risk of rupture. Multiplicity. Many studies have suggested that patients with multiple aneurysms have a higher risk of rupture. Some suggest that there's a shorter time before formation and rupture, and that could account for it, but this remains an open question. What about growth? Well, I'm going to highlight some more recent studies. Gondor in 2016 studied 292 patients with small unruptured aneurysms, 7 millimeters and less than 4 millimeters in the posterior circulation, and found the following. Probability of growth, 2.6%, which was increased in females, hypertension, dome size, multiplicity, and smoking. And there's an asterisk there to remind me to say that many others found that smoking was associated. And there's some that say, no, smoking is not a risk factor. The rupture rate increased with growth to as high as 6.3%. And the risk was greater, as we've seen already, in the posterior circulation and lobulation. So what about growth? There's been an increased interest in predictive equations, and this is just one of them that came out in 2017. The ELAPSE score had 6 predictors of growth: earlier subarachnoid hemorrhage, location, that is posterior circulation, age over 60, population, size, and shape. And this and other studies such as the phases, which is again predictive evaluation of rupture based on population, hypertension, age, aneurysm size, earlier history of subarachnoid hemorrhage, and site of the aneurysm, as well as another predictive equation and analysis, which was known as the UIATS, predictive score. All of these were built on very substantial patient sizes and data, but in the real world tests, they all have to a certain extent been found to be wanting, and I would just refer the listener to the chapter to dive into the discussion of these different methods of predicting rupture. What about symptomatic aneurysms? It's unclear whether the risk is independently higher or is just an epiphenomenon related to location, for example. Most symptomatic aneurysms prior to rupture appear to have perhaps an independent higher risk, but most symptomatic aneurysms are at the posterior communicating artery location, which is known a priori to have a higher risk. So is it really symptomatic, or is it the location? And size. In order for a posterior communicating unruptured aneurysm to become symptomatic, that is, press on the third nerve, it has to achieve a certain size. So in other words, size large, and it's not whether the patient is symptomatic, it's really the size of the aneurysm. So in summary, here's the aneurysm risk factors associated with rupture of intact aneurysm, and the number of asterisks are a rough approximation of the strength of the association, and you can see size, location, multiplicity, growth, less so for symptomatic, and inflammation I'll cover subsequently. So We finished with aneurysm factors. Let's look at patient factors. These are usually come into view sooner because you have to deal with the patient before you do the studies, although the way that modern neurology and neurosurgery practiced, I suspect you don't meet the patient, you meet the patient's CT first. Okay, gender. Aneurysms are observed more frequently in women, i.e. the prevalence is higher, and the risk of hemorrhage may be higher in women. That remains to be confirmed. But here's a study done in 1966. It was part of the initial aneurysm trials, significant component derived from the patient base at Atkinson Morley. And what we see here, I've reconfigured the data. Here we have gender ratio, so if males equal females, it's 0. And here we have increasing age. And you can see that males predominate in ruptured aneurysms in the younger group, and that at a certain point there's a crossover and women increase significantly thereafter. And the largest disparity by location is at the posterior communicating location, where females outnumber males by a considerable extent. But also note that the cooperative study showed, and this has been sustained, that the gender ratio is reversed in males. So with anterior communicating artery aneurysm, the population tends to be more male. What about age? Most of the literature supports a relationship between increasing age and increasing risk of hemorrhage. Hypertension, well, Stebbins, who wrote a wonderful textbook called The Neuropathology of Cerebral Vessels. I always urge folks to read it because it's a wonderful and encyclopedic book. Stebbins did not find an association between hypertension and the development or rupture of aneurysm. And this became the accepted truth, quote, end quote. But then in 95, Taylor evaluated 21,000 aneurysmal subarachnoid hemorrhage in Medicare patients in the U.S. and found increased prevalence of hypertension. There's always a problem in a patient that hasn't been under medical care before, who comes in with a ruptured aneurysm. Their blood pressure's elevated because of the intracranial hemorrhage. As to whether that patient has hypertension, quote unquote, is really not clear. But Taylor found that pre-existent hypertension was a harbinger of rupture. Now, remember, most of what I've spoken about, it really talks about correlation, not causality. In the laboratory, there are now good models of aneurysm development and aneurysm rupture, and almost every model, every experimental model, involves induced hypertension. So that's highly suggestive that hypertension is causally related to aneurysm rupture and probably development. What about smoking? Cigarette smoking is strongly associated with increased risk of aneurysm formation and subarachnoid hemorrhage. Most recently, the study by Javella. But in the lab, Dumont and others have documented that inflammation, in some cases by other investigators, by cigarette smoking itself, plays a role. Not focusing exclusively on smoking, but inflammation in general. Histopathology of humans and animal aneurysms support the concept that inflammation is involved in aneurysm formation and progression. And this was long championed by Nick Zervis, who was the chair at Mass General, published an article in 1968 that I think was probably accepted out of respect for Dr. Zervis, but most people didn't really believe that. Kayet followed it up with very nice studies in regard to inflammation, documenting inflammatory response around the neck of the aneurysm. And subsequently, there's been developed more and more data that suggests that inflammation is involved. So, for example, chronic aspirin, individuals who take aspirin on a chronic basis, it's been documented that the rate of aneurysmal subarachnoid hemorrhage is lower than those not taking aspirin. And this is a study by Hansen done at the University of Iowa, where he tagged macrophages and found that they were associated around the neck of aneurysms that were progressing on to hemorrhage. And then, as I've already referenced, there are experimental studies looking at TNF-alpha and other inflammatory markers which suggest causality. And then there's the human experiment, which is ongoing, and that is population-based studies indicate a decreasing incidence of aneurysmal subarachnoid hemorrhage with a decreasing incidence of smoking. And that's been observed in Finland, in England, and Canada. So it's probably, it substantiates the correlation and perhaps causality of cigarettes inducing aneurysms and aneurysm rupture. What about lifestyle? Binge drinking may account for a higher rate, both prevalence and rupture, in the extraordinarily high rates observed in Finland, and even the reverse of female to male ratio. Males are higher, and perhaps that's because they drink more. Otherwise, there's plus-minus support for alcohol, obesity, and metabolic factors such as diabetes. Let's turn now to sentinel or thunderclap headaches. This was defined by Richardson and Hyland in 1941. It's a severe headache that lasts approximately a minute. And Gillingham, who was a Scottish neurosurgeon in Edinburgh in 1958, termed these warning leaks, possibly caused by minor aneurysm tear. So this gained popularity, and subsequent studies suggested that subarachnoid hemorrhage from an aneurysm, subarachnoid hemorrhage causing this thunderclap headache or sentinel headache was followed within 2 weeks with a hemorrhage. But there are caveats, and these caveats are all the studies, as noted above, were retrospective, and the frequency was quite wide. So warning leaks, thunderclap headaches were found anywhere from 5 to 40% frequency. And the concept of a thunderclap headache, that is the traditional story that the patient will say, "Oh, it was the worst headache I've ever had in my life," was challenged by a very interesting study published in The Lancet, which found that 63% of patients, normal patients, in a GP practice stated that they had had the worst headache of their life sometime within the previous several weeks. So that threw the concept of sentinel headaches into question. But it's back on the table, and it looks to be a real story. MRI studies in 2015 revealed variation in the age of the clot of patients who had an aneurysmal subarachnoid hemorrhage. So in a group of 127 patients, 14 patients, or 12%, had recall of a, quote, thunderclap headache before their major subarachnoid hemorrhage, and 13 of the 14, or 93%, revealed a minor, that is an older clot leak by T1 flare mismatch. Overall, 34% of all patients on a T1 flare imaging showed a mismatch, which suggests that the warning bleeding is a real entity and that it occurs frequently before a major ictus. And that, as you'll see, would be compatible with a super acute bleeding, which I'll discuss subsequently. What about genetics? Well, genetics are being increasingly found to be causally related to a number of entities, and it appears like it is also involved in the formation and perhaps rupture of cerebral aneurysms. So, for example, familial frequency, that is in first degree relatives, the risk is substantially increased for rupture, and also prevalence. Polycystic kidney disease, well-known connection, perhaps via hypertension, but patients who have polycystic kidney disease and their families have an increased risk of prevalence and incidence. Japanese and Finnish population, I've already illustrated, have an increased risk perhaps. And then there are a variety of enzyme that have been associated with an increase prone to rupture. And I think at this point, the best approach would be to refer you, the listener, to this chapter in the textbook, chapter 425, which carefully, thoughtfully, and completely reviews the genetics of intracranial aneurysms. So, in summary, the factors associated with ruptured intracranial aneurysms, patient-related factor, and then the strength of the association is shown here: gender, age, hypertension, smoking, lifestyle, sentinel headaches, genetic and molecular factors, which I would urge you to go to the text to see more of the details. This is then the summary of patient-related factors and aneurysm-related factors in the risk of rupture of an intact aneurysm. And before we move on to the natural history of ruptured aneurysms, let me just mention the psychological burden that the patient bears when they are told that they have an unruptured aneurysm. It can affect the quality of life. It can affect insurance rates, which in turn could affect quality of life. And physicians need to remember that it's part of the natural history and can consider the psychological effects of carrying the diagnosis of an ruptured aneurysm. And this is, again, defined and reviewed in chapter 425. So having finished with the unruptured aneurysm, let's turn to the ruptured aneurysm, the natural history, and it's going to be broken down into two parts: acute, 0 to 6 months, and long-term, greater than 6 months. So let's look at the acute natural history. Once an aneurysm ruptures, the primary cause of death and disability: initial hemorrhage, rebleeding, associated complications such as vasospasm, hydrocephalus, and medical complications, primarily infections, and that's in the poorer grade patients. Here's a study from the American Heart Association, which looks at direct effects in yellow, in purple, we see a rebleeding. Then we see vasospasm coming on somewhat late, and medical complications also late and low. But this early rebleeding, which is in fact the only factor related to the early component of the natural history after the aneurysm rupture that we can effectively influence, this early rebleeding occurs within 24 hours, but that may be not the true story. This appears to be an underestimation, and here is a study published in 2001 in 273 patients that looked at acute rebleeding within 8 hours of the initial hemorrhage. What we see in red is the number of patients, and in blue the percentage of those patients who bled in the first 8 hours. And these patients undoubtedly, like intracerebral hemorrhage, are undoubtedly missed when we try and build the history and define the natural history after rupture. So, what about mortality? Mortality is associated with grade on admission, time from hemorrhage, rebleeding, and location. I got those out of order. Okay, what about grade versus mortality? Which, if we go back one, can't go back. The association between grade and mortality at 6 months. This comes from a study, again, the long-term outcome study that was done at Atkinson Morley's Hospital on more than 1,000 patients. Grade 1, Hunt and Hess, 15%, grade 2, 30%, 50%, grade 3, grade 4, 65%, and 95% in grade 5. Not too surprising, but there are some interesting data that came out in regard to disability, and it's surprising how the poorer grades, if they survive, were not that incapacitated. And this study was confirmed subsequently by Phillips from the Mayo Clinic, showing a similar spread in survival after aneurysmal subarachnoid hemorrhage. Here's a different way to look at it, and this is Loxley's publication as part of the cooperative study. This curve is a regression curve of survival following subarachnoid hemorrhage, 830 single aneurysms. And there's a way you can strip out the rates here, and you see the different rates. So, for example, K3 has a half-life. It's measured in hours, and that represents about 9% of this population. In other words, it's equal to grade 5. Grade 2, or K2 rather, represents 47%. That's where it intersects the y-axis. Their T half-life is measured in days, and this is comparable to grades 3 and 4 on the Hunt and Hess scale. And then grade 1, shown here, represents grades 1 and 2, and 43% of the population, and the half-life as measured in months. Time from hemorrhage. This is kind of an interesting way to look at it, but it's important when you analyze the results of publications or studies. This was done by Alvord in 1972. Buster Alvord was a colleague of mine when I was at the University of Washington. He was head of neuropathology, very mathematically oriented, and a wonderful colleague and friend. So let's just look at this curve, these curves. It's the predicted mortality versus all death time, and so he plotted here time after a major subarachnoid hemorrhage and percent alive. So let's say, and this is perhaps why this is important, even though it's an oddity of some type. You are standing in the ER when a patient comes in, or in the hospital bed, and the patient grabs their head and says, "Oh, this is the worst headache I've ever had." And the family then asks you, "Well, doctor, what is the likelihood that our loved one's going to be alive 1 month from today?" And here's where you go out here to 1 month, and it turns out that the patient has a 45% chance of being alive 1 month later. But you're a busy clinician, and you didn't have time to see the patient right away, and you delayed seeing him, or you were delayed by 1 day. And the family says, "Doctor, what's the likelihood that my loved one will be alive 1 month from today?" And now, instead of 45%, lo and behold, by doing nothing, the chances of survival are above 60%. But you're a really busy clinician, and you can't see the patient, or doesn't get referred in, or comes from far away, and doesn't get to see you till 7 days after the subarachnoid hemorrhage. And the patient's family says the same thing. What's the likelihood my loved one will be alive 1 month from today, 3 weeks from now? And lo and behold, it's now up to 80%. Now, this doesn't mean that you ignore the patient, but what it does mean is that when you evaluate therapy, you have to take into consideration time from original subarachnoid hemorrhage. Because obviously, this, shown in this next slide, 0 time, 45%, 1 day, greater than 60%, 7 days, 80% survival. This represents the fact that the patients are rebleeding, most in the poorer grades, but certainly not exclusively, and patients in grade 1 and 2 will rebleed. But those patients are being removed from your care or your consideration or off the chessboard. So that's something to consider. What about location? Here's another study that we did looking at aneurysm location versus mortality at 6 months. Again, patients relegated to bed rest, and the anterior circulation, that is anterior communicating, posterior communicating, middle cerebral, in the 30% mortality at 6 months. Multiple aneurysms, higher probably because some of the posterior circulation aneurysms were mixed in, and posterior circulation 61%. So location influences outcome, and I'll go into this subsequently. What about rebleeding? So I'm going to spend a little time discussing rebleeding because that's the cataclysmic event. If the initial hemorrhage doesn't result in demise of the patient, the subsequent hemorrhage will, if not rebleeding, if not vasospasm. So rebleeding by 6 months in general occurs in about 50% of the patients, and this is based on many studies, but is exclusive of what I previously showed you, the superacute hemorrhages that occur within less than 8 hours. Acute rebleeding, now I'm not talking about mortality, just rebleeding, but rebleeding, of course, influences mortality. Acute rebleeding is related to time from hemorrhage, location, and grade. So here's the study by Cassell that I showed you previously, which showed this peak in the first day, And most recent studies, as I've hinted at, suggest as high as a 14% rate in the first hour with a peak time in 2 hours, 77% of all the hemorrhages. And that has to now be factored into the natural history. So what are the factors associated with rebleeding? Here's from a box on the chapter 425.2, superacute, poor grade, intracerebral hemorrhage, subdural, systolic hypertension. Those factors are correlated with acute rebleeding, less than 8 hours, but acute rebleeding as measured in days, clinical grade, aneurysm location, and I'll go into that a little bit detail in the next several slides. Anterior communicating versus posterior communicating, two of the most common. So here it is, location, and what's important to remember is that not simply the location is tied to rebleeding, but even within the same location, the aneurysm, there are aneurysm factors that can affect rebleeding. Here we see the relation to elapsed time versus chances of rebleeding and the influence of aneurysm location, and restricted to grades 1 to 3. And you can see that posterior communicating has the highest chances of rebleeding. And that was confirmed, but the USIA study suggested that the initial hemorrhage was also higher in PCOM. Well, here's a very intriguing study done by Alan Richardson, John Jane, and Payne, published in 1964. They looked at a large number of anterior communicating and posterior communicating artery aneurysm patients, and they attempted to discern what were the factors that would predict rebleeding. Now, this was just from one location, and they performed one of the earliest discriminant function analysis done in a surgical population, and they looked at these following factors and created a discriminant function, and just one of them I'm going to highlight, and that had to do with the direction of pointing of the anterior communicating artery. So if it was up and forward, the risk of rehemorrhage was much greater than if it was forward and down. But there were other factors as listed here. And for the posterior communicating, that should be posterior communicating, and this is anterior communicating, the factors were somewhat different. So for anterior communicating, age, gender, blood pressure, level of consciousness, shape, and direction, whereas posterior communicating artery aneurysm, females, presence of spasm, presence of hematoma, size, all influence the likelihood of rebleeding. So there's an influence or a correlation between the configuration of the aneurysm, the geometry of the aneurysm, and the location. So even within the same location, you can have different rates defined by different aspects of the aneurysm. That's a summary of factors associated with rebleeding. Now, that's the acute natural history of ruptured aneurysms. Now let's turn to the long term. That is, what is the outcome of patients who survive more than 6 months? And this was at the time an important component of the natural history that was not known. And in part, there was the belief that if the patient survived to 6 months after an aneurysm rupture, the aneurysm was healed and the patient no longer faced a risk of hemorrhage. It was a very strongly held belief, especially in the neurology community, who believed that this was a valid observation and that the patient did not need further investigation. So what is late rebleeding? It's defined as a subarachnoid hemorrhage 6 months after the original episode. And to analyze this, we studied many patients, more than 1,000 patients, who were randomized to bed rest therapy as part of aneurysm trials at AMH for the treatment of subarachnoid hemorrhage. None were in danger of dying, and they were followed for 10 to 20 years, as I will show you. And here's a picture of Atkinson Morley Hospital. Not very impressive, but it was an amazing institution, now incorporated into St. George's. They would see somewhat times as high as 900 patients with subarachnoid hemorrhage, because it was the only neurosurgical center south of London, all the way to the Channel and all the way to the Atlantic South. And here's an interesting book written by David Utley, who succeeded Alan Richardson, giving the history of this wonderful institution, which is now an upscale apartment in Wimbledon. And here's some of the publications that were produced by Wiley McKissick and Alan Richardson, truly seminal publications with hundreds of patients in these groups that they randomly allotted to either surgery or bed rest. And the surgery was a variety of different types of surgery. So here's middle cerebral artery aneurysm. Here's posterior communicating artery aneurysm. Here is anterior communicating artery aneurysm. Here's an example. 457 patients were evaluated just in one location. So here's the natural history and long-term outcome of the patients who survived 6 months. And this is just one group, anterior and posterior communicating. Initial population 364, surviving to 6 months 213, and you'll see late rebleeding demonstrated here. Fatal and non-fatal. What you can see that bleeding persisted despite the belief that the aneurysm was healed. And this demonstrated our approach to considering the 12% of the population that were lost to follow-up. So in red is the patients who bled. Here's the patients in black who fatally rebleed. And the upper limit in this curve assumes that the patients lost to follow-up rebled in the year, but were lost to follow-up. And in the lower limit here assumes the patients lost to follow-up were alive for the entire 10 years, but again were lost to follow-up. And the same applied here. And this demonstrates a different group. This is the anterior communicating group, 167 patients initially, now followed out into the second decade. And if you look at all the follow-up here, just in the anterior communicating, but it also applied identically to the posterior communicating, the average late rebleed was about 2.74% over 2 decades. Excuse me. Whoops, I have to go back. Well, what it showed was that the risk of bleeding was 3 to 5%, and the risk of fatal rebleeding was 2 to 3%. So that was the early, as I said, the early phase. I've been talking about the late phase. I covered late rebleeding. Let's look at late mortality. And to do this, we matched the observed mortality, but that was after we removed the patient who died from subarachnoid hemorrhage. That is, the patients who re-ruptured their aneurysm anywhere from 0 to 10 years. And what we found, we matched it to an expected survival based on insurance data in an English population, and we found this disparity that even discounting the patients who died from subarachnoid hemorrhage, the mortality rate was higher in these patients. The majority of the deaths were related to cardiovascular problems, such as myocardial infarction. So cerebral aneurysm in this population is just one sign of the diffuse cardiovascular and cerebral vascular disease. One last aspect, late epilepsy, something that's not mentioned or studied much these days. But what we see is that late epilepsy, that is, that occurs after 6 months, here's the rate in anterior communicating. Again, I remind you, these are patients that were relegated to bed rest, not operated on, not coiled, hadn't even heard of that at this era. So anterior communicating, 2.5%, posterior communicating, 9%, middle cerebral, 25%. So what could account for these high rates of late epilepsy? Well, for example, in the ISAT study, the initial coiling study, the seizure rate was less than 1% after 1 year. And so what are the possible conclusions? There's longer follow-up required in the ISAT study. Maybe it was incomplete follow-up, since I believe it was mainly by postcard. Perhaps it was the introduction of anticonvulsants. And a fourth one, which I didn't list, but what some WAG has suggested, is that platinum is a anti-seizure factor. So, okay, I've come to the end of this talk, and here's the summary. The natural history of aneurysm. Intact aneurysms rupture at a rate of approximately 1 to 2% per year. There are multiple factors that can increase the risk. There are patient factors and there are aneurysm-related factors, and they're listed here for aneurysm factors and here for patient factors. What about the natural history of ruptured aneurysm? The acute natural course, that is 0 to 6 months, death is related to initial event and rebleeding. Rebleeding is associated with time, grade, and both inter and intra-location. So it varies by location within the cerebral vascular tree, but also variation within the same location depending on the configuration and other factors of the aneurysm anatomy. Ultra early bleeding occurs. 2 hours of those patients, bleeding is frequent. It's in 14% of the entire population analyzed. What about the late course? That is greater than 6 months. Rebleeding occurs in total 3 to 5% per year. Fatal rebleeding 2 to 3% per year. Overall mortality is increased compared to a matched population, and seizure rate varies between 2.5 and 25%, depending on the location. With that, I've come to the end, and I thank you for listening.